And this will be now a symposium, and we will discuss latest data in patients with liver cirrhosis and how to improve treatment outcome in treatment-naive patients if we alter the treatment duration. And also we will discuss on resistance in this symposium here. So we have the possibility to interact with you, so you can vote. You have these voting cards. Simply hold up the card of your choice. It's very easy, no digital things. And I have a test question for you, actually. And this is the test question: what color sauce is Frankfurt known for? So if you're not coming from Frankfurt, I'm originally from Cologne, you're not used to that sauce, actually. The typical Frankfurter is taking the sauce together with boiled beef, of course potatoes, sauerkraut, and cider. So what do you think is the color of that sauce? Just vote, please, now. I see some red and some yellow, but I'll see also a lot of green, and green is correct, actually. So you're right with the green. It's a green color. It's a sauce of 7 different herbs, and Frankfurt is very well known for that sauce. So let's move on. I start with the end. I remind you now to fill in the evaluation forms. I know that you're all in a hurry when we stop at the end of the meeting, and therefore let me now remind you to complete these forms. It doesn't take a long time, and if you want to have it even simple, very simple, just tick all the boxes on the right-hand side and then it's already done. So let's move to our topic, hepatitis C. On this graph here, you can see the ship of hepatitis C, like a big ship on the ocean, out of control. And also you can see anchors, and these anchors were set into the water to get this threat under control. And I think we all agree that one of the very first anchors which were set, of course, was the discovery of the virus. And together with this, also the establishment of the first treatment options, interferon alpha, and the screening for hepatitis C, and the combination therapy, interferon alpha and ribavirin, and so on. And then the next milestone to me would be the development of the cell culture system, the HCV replicon, because only with that system we were able to screen at a high throughput level for small molecules to block the replication of hepatitis C. And indeed, after the development of that replicon system, a number of direct antivirals have been developed and then later approved. And of course, we all know that within the far past 15, 18 months, now we have a number of direct antivirals in our hands, and we combine these direct antivirals, and the big promise was that irrespective of the combination you use, you will kill the virus in 100% of the patients without any importance of genotype, subtypes, stage of cirrhosis, and so on. But of course, we know that this is not quite true. We still have some challenges, and we know that only based on treatment individualization, we really can optimize the outcome of the treatment. We have not a large number of treatment predictors anymore, as previously with interferon alpha and ribavirin, but there are some which seems to remain of importance. Cirrhosis, for example, some patients' characteristics. We have heard about cirrhosis, post-transplant status, renal failure, but also viral factors like viral load. We know that, of course, the experience to previous treatments is important, and viral polymorphisms. And virus polymorphisms, to me, also include the different genotypes and the subtypes, but also, of course, resistance-associated polymorphisms. And of course, this will be one of the topics we want to discuss today. And here is the agenda of today's symposium. We will have 3 presentations and afterwards a panel discussion. So in the first presentation, Ashley Brown will discuss what possibilities do we have for shorter treatment options, 8 weeks versus 12 weeks. Then myself, I will give a presentation on patients with cirrhosis, and Christopher Zode will give the outlook for the future. What can we do? What can we expect for future developments, and also what can we do with those patients who fail to achieve a response with the current regimens? So, Ashley, let's start with your presentation.
Thanks very much. Thank you, Chris. Thank you to the sponsors for inviting me. I have to say it's been a fantastic afternoon. I've learned an awful lot of facts this afternoon, but the most interesting amongst those is that Frankfurt is famous for green sauce. I had no idea. Right, okay, so talking of colours, the fashion world will tell you that brown is the new black. No, I'm not changing my name, but I would like to tell you that now 12 weeks is the new 48 weeks. The reality is that for most of the time that I've been treating hepatitis C, for genotype 1 non-cirrhotic patients, we were looking at 48 weeks of treatment. The reality is now, with the all-oral combinations, that we're pretty much treating every genotype 1 patient with 12 weeks. Why have we come to that conclusion? Well, let's just have a look at the clinical trials that have given us those conclusions. So this is the aggregated data from genotype 1 non-cirrhotic patients treated with the various combinations of all-oral drugs that are now available to us here in Europe and in the United States. The Optimist 1 study, looking at that, the first all-oral combination, SimSof. Interestingly, the study came after clinicians were using that combination, but the combination of cimetravir and sofosbuvir in genotype 1 patients, 97%. The ION studies, the Gilead studies, looking at sofosbuvir, ladipasvir combinations. Again, in the 12-week arms, we can see there that they passed that magic level of 95%, so in excess of 95%. The AbbVie 3D combination, the Sapphire study, originally looking 12 weeks with ribavirin, both treatment-naive and treatment-experienced patients, again, SVR rates in excess of 95%. And the Pearl studies, looking at whether or not that combination with the addition of ribavirin was necessary, once again, 12 weeks have surpassed that level. And finally, we've heard a lot today about the combination of sofosbuvir declatazvir, now available in the US. We've been using it here in Europe for a little longer. But in the ALLY study, this was in co-infected patients, again, 12 weeks, sofosbuvir declatazvir achieved SVR rates in excess of 95%. So the question we have to ask ourselves is, if we're doing it that good, are we perhaps over-gilding the lily? These are not cheap drugs, we know that, and so therefore, can we identify maybe that not everybody actually needs 12 weeks? So let's have a look a little bit deeper into the data to see whether there's any clues about which patients are doing particularly well and which ones are doing less well, and maybe that will guide us. So this here is the breakdown of the Optimist data. Remember, there was an 8-week and a 12-week arm in Optimist, but I'm just looking at the 12-week arm here. But what you can see is that regardless of whether patients were treatment naive or experienced, 1A or 1B, or whether or not they had that Q80K polymorphism, the outcomes were exactly the same. So all those rules that we learned in the days of PEG-RIBA can just be thrown straight into the bin. This is looking at that ALLY-2 data. Remember, again, this is co-infected, but once again, we can see that however we break it down, naive versus experienced, 1A versus 1B, the results are exactly the same. So no clues there as to who we're over-treating and who perhaps we're under-treating. And we've talked today about NS5A mutations. That seems to be the next big buzzword. Heiner was explaining how we need to get a grip on that. But again, looking at baseline mutations, so these are not drug-derived mutations, but baseline mutations, even when we're using an NS5A inhibitor in the mix, it would appear that baseline mutations make no difference. This is looking again at the AbbVie data. So on the left, we've got the 2 Sapphire studies. So again, naive and experienced. All of them had 12 weeks. All of them had ribavirin. We've split it here by subtypes. No difference. The Pearl studies looking at that, the necessity to require ribavirin. In the 1B studies, in the Pearl 3 and the Pearl 2, no difference whatsoever with or without ribavirin, hence ribavirin is not required on the license. It's only when we look at that last study there, the Pearl 4 study looking at the genotype 1A patients, that there was a numerical difference with the omission of ribavirin, suggesting that maybe those are slightly more tricky patients and that ribavirin may be required. So why are we not satisfied? We're like spoilt children. We always want to do something better. Why are we not happy with 12 weeks? Well, I'll tell you why we're not happy with 12 weeks. 12 weeks, we could do better. We are very happy with 12 weeks because, as I say, we've been used to treating for 48 weeks for the past decade. Patients who've had 48 weeks in the past are very happy with 12 weeks. But the patient that's never been treated before, 12 weeks seems like an eternity. So it may well be that 8 weeks is a better way to go. What about use of resources? Now, at the moment, I'm trying to get 250 compensated cirrhotics through my clinic into treatment over the next 3 months. Clearly, treating patients for just 8 weeks rather than 12 weeks means that we can increase capacity through our clinics by 50%. And we were seeing those figures from Homi Razabi earlier on, showing that we've really got to increase the numbers of patients that we're treating. What about the drug costs? These drugs are not cheap. So reducing 12 weeks to 8 weeks theoretically could give our payers a 33% rebate. And what about those difficult to treat patients? More than half the patients I'm treating at the moment are in methadone clinics or prisons. They're slippery customers to keep hold of. And by offering 8 weeks at the outset, it might be that makes it more acceptable to those individuals. But none of us want to sacrifice efficacy at the cost of shortening treatment. So we really need to be sure who we're treating. So here's my first question to you. You've all got your cards, red, yellow, green, or blue. Would you be prepared to reduce treatment to 8 weeks in your patients? Yes, we should consider it. In most patients, I can always offer that small number of patients who fail some sort of rescue therapy. Green, yes, I would consider it, but only in selected patients. Yellow, no, we should not be shortening it because we simply don't have the evidence yet and are not prepared to sacrifice it. Or blue, there's no need to shorten it anyway. 12 weeks is absolutely fine. Right, vote now. It's like Australia. I've just come back from Australia. Voting is compulsory there. If you don't vote, you pay a fine or you get sent to prison. So red, green, yellow, or blue. There's no right answer. I just want to see. What do we think, Chairman? Majority of greens there. So we need to know the favorable characteristics. Okay, let me introduce you to one of my patients, a real patient. Again, contrary to what Nid was saying earlier, we're not just treating Child-Pugh B and C in England. We're now allowed to treat anybody with fibroscans over 11.5 and anybody with extrahepatic manifestations. This is one of my patients, 57-year-old, long history of injecting drug use. He's been clean for a couple of years now, used to drink heavily. He's cut that back a bit. He's stable on a methadone program. But he's got evidence of vasculitis, so we're allowed to treat him for his extrahepatic manifestations. His genotype 1A, he's got a high viral load. He is HIV negative. You can see his bloods there. His fibroscan of 7.4. So we decided we were going to give him 12 weeks of sofosbuvir/ledipasvir in line with our guidelines, planning for 12 weeks. Comes along at week 2, good adherence. I should say also, incidentally, the way that we get our patients to turn up to the clinics is if they turn up, they get a £5 voucher for Marks and Spencer's, and they can go and buy themselves a sandwich. We think that's a very small outlay when we're paying tens of thousands of euros for the drugs, and it means they come absolutely every time. So maybe Heine needs to give out some vouchers. Week 4, feeling stronger. Now his HCV RNA is undetectable. Week 6, he's carrying on being compliant. And at week 8, he fails to turn up. Now, my nurse is very good, my outreach nurse. She gets on her bicycle and she goes around the tattoo parlors and the crack dens and she tracks these patients down. She managed to find his partner who told us that he'd been arrested on an assault charge and he'd been sent to prison and he couldn't get bail. So, will 8 weeks be enough for this patient? Let's look at that data. So you remember the ION-3 study. Now, the ION-3 study looked randomized patients to 12 weeks of sofosbuvir/ledipasvir, 8 weeks of sofosbuvir/ledipasvir plus ribavirin, or 8 weeks of sofosbuvir/ledipasvir without ribavirin. None of those patients had on-treatment failure. The only virologic failures were relapses. When you look at the top-line data, you could say, well, there's no difference, 94, 95, 93. But when we look at the relapses, you will see that 20 out of the 23 patients that relapsed did so on the shortened duration therapy. So let's look a little bit closer at those relapses to see if we can see why it was they failed. So what we can see is that 17 of the relapses were male. And again, you can see there the shorter duration therapy in men seem to have a higher relapse rate. Good old IL-28B genotyping raises its head once again, and we can see that those with the unfavorable IL-28B genotypes were more likely to relapse. And the final factor that seems to contribute would be high viral load. So we can see there that maybe those are not the ideal patients to be giving the shorter duration of therapy. You remember the Optimist study. Now again, I showed you the 12-week data, but there was an 8-week arm in the Optimist data. And again, we can see here that the relapse rates, or the SVR rates, were poorer in the 8-week arm when we break it down, again, by level of viral load, 1A versus 1B, and again, the IL-28B genotypes. So what we can see is that there are categories of patients that perhaps do less well on the 8-week arm. And what about the polymorphisms? So Q80K, we know that that is important when we've got sofosbuvir in the mix. We can see there that shorter duration in Optimist in those patients with Q80K was important. Interestingly, however, in the Aviator study, which didn't use sofosbuvir, that was the AbbVie 3D regimen, there was a slight reduction in the shortened duration arm with the Q80K polymorphism. And again, those NS5A polymorphisms, we can see there that those with the baseline RAVs in the shorter duration arm probably had a slightly poorer outcome. So what we're beginning to see now is a picture where there are both host-related factors and viral-related factors that maybe might suggest to us which patients will be fine on the shorter duration, but which ones we should probably stick with the 12-week arm. So when we use only 2 directly acting antivirals in 8 weeks, we are putting a stress on it, and until we come through with triplet therapies, we need to be cautious about those patients that we shorten duration therapy on. So, bearing in mind what I've told you, let's vote again to see whether I've changed anybody's mind. How do you feel about 8 weeks now? No, not at all. Yes, but only when we know favorable factors. No, we don't need to, or no, there's simply no data. Red, green, yellow, or blue, vote now. I'm delighted to say that I think there's probably a few more extra green ones there and a few more yellows. So, you want to know what's happened to my patient, don't you? Here we go. Despite multiple attempts to try to get hold of him, we were unable to do so. We couldn't work out which remand centre he was in, and he was moved around because of overcrowding in prisons. We seem to have a habit of sending all of our people to prison in Britain. Not quite as bad as the Americans, but we're getting there. His case came to court 8 weeks later. He was given a 12-week sentence, and he'd already spent 12 of it on remand, so he only had to go to prison for 4 more weeks. And he came back to the clinic 14 weeks after swallowing his last tablet. Remember, he'd only had 8 weeks because we'd only been able to give him 8 weeks. He was HCVRA negative. So although my guy had some bad factors, perhaps he was just lucky and he did manage to get his SVR. So in summary, I hope that I've shown you that 12 weeks of treatment with interferon-free regimens is now well established as standard of care therapy for genotype 1 non-cirrhotic patients. And that shorter duration therapy may be effective, but not in every group. We really do need to be looking at this now so that we can identify which characteristics determine those patients who will benefit from a shorter duration of therapy. Thank you very much.
So, thank you very much. Are there any burning questions? If not, we just move on with the next presentation. I now will discuss the more difficult to treat patients, and of course you have sufficient time at the end during the panel discussion to ask all your questions. So we have heard about the non-cirrhotic patients, and that was more or less straightforward and easy. Some issues with 8 weeks. Let's have a look about liver cirrhosis. And I think before we start to discuss about patients with liver cirrhosis and whether we should treat these patients for 12 weeks, for 24 weeks, and what is the importance of additional parameters like the addition of ribavirin or baseline resistance. We should discuss about the definition of liver cirrhosis. And I show you that this is not as easy as we might think. We have different parameters to assess whether a patient is a cirrhotic or not, but there is no real gold standard. Liver biopsy, if you ask the pathologist, of course, is considered to be the gold standard, but in reality, this is not really true. We also have here some ups and downs, some advantages and disadvantages. If the length of the liver biopsy is insufficient, if the number of portal tracks is not sufficient, then of course it's very difficult to assess cirrhosis or non-cirrhosis. And of course also we have a huge inter-observer variability with liver biopsies. Laboratory tests. There are a number of tests, indirect and direct parameters, but also here there is no gold standard. There are variabilities between patients, between labs, lack of standardization, and so on. And finally, there are a number of mechanistic approaches measuring the elastography of the liver by either the FibroScan or the RFI ultrasound-based measurements or MR elastography. But again, also here, we have advantages and disadvantages, patients where we can't use it, and others where it's working very well. So the solution of that was shown to be a combination of the different methods, and only with these scores and algorithms established, we now can really assess whether we have a patient with cirrhosis or without a cirrhosis with a certainty, accuracy of above 90%, and that is really what we are doing in our clinical practice. And indeed, the status cirrhosis or non-cirrhosis matters. We have seen that in our previous presentations here during the afternoon, and I just want to show you one example here, the follow-up of these patients. If you have a patient without liver cirrhosis and you achieve an SVR or you don't achieve an SVR, the likeliness for the development of liver cancer is relatively similar. However, if you have a patient with liver cirrhosis, you have a huge remaining risk of liver cancer. There's a significant decline, a risk reduction if you achieve a viral eradication, but the risk stays at a significant level. For example, here in that study with a long-term follow-up of several years, there was still a remaining risk, cumulative risk of approximately 20% in SVR patients for the development of liver cancer. So obviously we need to know that. And we also need to know that, of course, because liver cirrhosis is a very important predictor of response. And this is, as long as we do treatment for hepatitis C, the case. You can see that this is consistently the case for all regimens here in the past and in the present. For PEC-RIBA, a significant lower SVR rate in patients with cirrhosis. For the triple therapies, telaprevir or boceprevir, a lower response rate in patients with cirrhosis versus non-cirrhosis. But also with the current interferon-free regimens here, an NS5A plus a nuke, a protease inhibitor plus a nuke, or the 3D regimen, there's always a slight decline of around 5% success rate in those patients who have established liver cirrhosis. So if you take this, of course, we want to know what is the reason for that, how can we avoid that, what are additional features which influence on the efficacy of our interferon-free all-oral regimens. So in principle, we have these three options, a PI plus a nuke, an NS5A plus a nuke, or the 3D regimen. And I want to discuss with you now what is the importance of the stage of liver cirrhosis, child A, child B, child C, with different features, and what is the importance of the addition of ribavirin? And finally then, what about baseline resistance? Is that also something which influences the efficacy of our interferon-free DAA combination regimens? So let's start with the stage of liver cirrhosis. And I think we now have a increasing evidence that for all interferon-free regimens with increasing stages of liver cirrhosis, we have a decline of efficacy. For this study here, we have patients treated with cimeprevir plus sofosbuvir for 12 weeks, only cirrhotic patients, of course. And if we take a parameter for portal hypertension, platelet counts, we clearly see that with decreasing platelet counts, the efficacy is also declining. If we look for liver synthesis, albumin, again, with decreasing albumin levels, also the SVR rates are coming down. And finally, a parameter for the stage of liver cirrhosis, FibroScan values above 20, there's a significant decline of efficacy. But this is not only true for this combination, it seems to be the same, very similar also for other combinations. Another example is coming here with the NS5A plus NUC combination plus ribavirin for 12 weeks. Patients with child A to child C stage cirrhosis were enrolled. And you can see, again, with an increasing stage of cirrhosis, child C, higher or lower SVR rates, higher failure rates. With ascites, again, as a feature for portal hypertension, the success rate is going down. For the hepatic encephalopathy, advanced cirrhotics, it's going down. For albumin, again, as a synthesis parameter, it's going down. And also for bilirubin levels, there's a decline of efficacy. And finally, I show you data here from another combination, NS5A plus sofosbuvir, ledipasvir plus sofosbuvir plus ribavirin for 12 or 24 weeks. And also here we see a declining efficacy in child B, child C patients. Interestingly, the declining efficacy is associated with virologic failures, but also with other failures, deaths, complications, adverse events are also more and more important in these late-stage patients. So let's move on. What about ribavirin? Is ribavirin important in these patients or not? We have discussed already that there's a lack of studies without ribavirin and longer treatment durations, but we have some studies where we can compare directly the addition of ribavirin. And for example, here with sofosbuvir and ledipasvir, NS5A plus NUC, we know from this retrospective integrated analysis of a large number of patients with cirrhosis, more than 500 patients were enrolled in that retrospective analysis, that ribavirin seems to be of importance. There's a slight increase here in patients who were treated without ribavirin versus those who received ribavirin for a 12 weeks treatment duration. It's not very much. There's an increase from 96 to 98 in the treatment-naive patients, 6% increase in the treatment-experienced patients, so there's a slight improvement. One could argue that there's a further improvement if you would go for 24 weeks, but this is of course only very little, and this is the reason why now in many guidelines the treatment with ledipasvir and sofosbuvir in cirrhotics is recommended with the addition of ribavirin, but only for 12 weeks. If we look for simapravir plus sofosbuvir, protease plus sofosbuvir, the situation is not quite clear. If we look back to the COSMOS study, where we had a direct comparison in treatment arms with and without ribavirin, there was a slight trend, but small numbers that ribavirin was slightly better. But in the Optimist study, there is no arm with ribavirin. If we look to the real-world studies, and these are larger numbers, there seems to be no big difference if we use ribavirin or if we just treat with simapravir and sofosbuvir alone. So it's not really clear whether ribavirin really helps to improve the efficacy in these patients. What about the 3D regimen? I think here the situation is a bit different. We know that this regimen is strong in 1B patients. So in cirrhotics, here on the left-hand side, there is no difference in efficacy with and without ribavirin. This regimen is only approved in child A patients, so these are early cirrhotic patients only. For 1A patients, it was already clear that for the non-cirrhotic patients, the addition of ribavirin is required. There was a statistically significant difference, and therefore there was no study to explore whether we need ribavirin in patients with cirrhosis. So it's very clear that for 1A patients in the 3D regimen, always ribavirin has to be added, and in few patients with additional negative predictors, we even have to extend the treatment duration to 24 weeks. So finally, what about resistance? Baseline resistance is something which is not usually generally assessed in our patients. However, it could be that this is becoming more and more important. And before I start to show you some data, I will ask you a question about your clinical practice. Are you doing resistance testing in all of your patients, irrespective of the status of liver cirrhosis? Then please vote with the red color. If you do it in patients, but only in those with liver cirrhosis, because this might be an additional negative predictor, you can vote with green, please. Yellow would be yes in treatment-experienced patients with cirrhosis, so 2 negative predictors, or just blue, no, I never do resistance testing, this is worthless. So please vote now. I want to see the colors. You have heard about the Australian rules for voting, so please don't be shy. Not everybody is voting actually. So I see a lot of blue, some yellows, but nobody's voting with red or green. So resistance testing is not really done very frequently in our clinical routine nowadays. Perhaps this will change in the future. We will learn also by Christophe Hizaut's presentation whether this might be required or not. So let's have a look on the data, what we do have currently in our hands. This is a study which you have seen already by Ashley. These are non-cirrhotic patients treated for 12 weeks. We have learned that if you have 12 weeks treatment in easy-to-treat patients, there is no difference at all in respect of baseline resistance. QADK with and without, same SVR rates. The stress test here was to reduce the duration to 8 weeks. Let's see now what happens if the stress test is not the reduction of treatment duration, but the addition of cirrhosis. So let's have a look on the results in cirrhotic patients treated for 12 weeks. And interestingly enough, here now it becomes obvious that baseline resistance plays in and is of importance. So for genotype 1a patients with QADK, the SVR rate is somewhat lower in comparison to those without QADK. So obviously, also liver cirrhosis is an additional stress test to our patients, even if they receive the 12 weeks treatment duration. And I want to show you that this seems to be true not only for semaglutide plus sofosbuvir, but also for the other DAA combination therapies. But let's have just a look on the QADK prevalence, just to remind you that not in all countries this is a frequent variant. In the US, we know that about 50% of patients harbor QADK, the 1A patients only. In Europe, it's quite diverse. We have countries where the overall prevalence of that variant is around 2%, and in others it might be up to 30% or so. So really look at your country, and then you can know whether this is important for you or not. So let's move on to other treatments. This is an NS5A inhibitor plus a nuke, ledipasvir plus sofosbuvir. And this is a study in patients with cirrhosis because this is the stress test. And indeed, you can see that if you look for overall, the SVR rate was 98% in those patients without baseline resistance, and 89% in those patients with baseline resistance. And baseline resistance is something which affected 13% of the patients, so it's a significant proportion of our patients. Interestingly, it seems to be even more important in 1A than in 1B patients. As you can see, the SVR rate drops down to 85% in the 1A patients with baseline resistance. Further, we could assess the level of resistance. It might be that low-level resistant variants are not of importance or less important than those with a high-level resistance. And here's a sub-analysis in patients which harbor only these 100-fold resistant variants. And indeed, if we take into account only these highly resistant variants, the picture gets even clearer. And you can see in the genotype 1 treatment-naive patients, the SVR rate is going down from 100% to 92%. And in those patients which have another stress test, treatment experience plus cirrhosis plus baseline resistance and high-level baseline resistance, then even the numbers are going down to 67%. So obviously here in this subgroup of patients, baseline resistance matters. And this is foreseeable, and perhaps we can avoid this if we just do baseline resistance testing in these patients. Finally, what about the other combination therapy with dacladasvir plus sofosbuvir, the other NS5A inhibitor? And here I show you an example in genotype 3 patients. Sofosbuvir plus dacladasvir now is an alternative standard treatment for many genotype 3 patients. Alternative to sofosbuvir plus ribavirin for 24 weeks, you can use this regimen for 12 weeks. We have an approval study, the ALICE3 study, and you know that the SVR rates were quite high, 96% in non-cirrhotic patients, but in patients with cirrhosis, it was already lower, only 63%. And if we now take into account also baseline resistance, it's interesting to see that a minor resistant variant at position 30 of the NS5A protein has no impact in patients without cirrhosis, but a huge impact in patients with cirrhosis. SVR rate is going down to 20%. And if we look for the major resistant mutation, which is Y93H, this was present in 9% of our patients. Even in non-cirrhotic patients, there's a significant drop of efficacy. And in the cirrhotic patients, again, the SVR rates are going down very much. Around 25% of these patients then only achieve an SVR. So clearly, if we have additional stress factors, cirrhosis, pretreatment, and the baseline resistance, then we clearly see a significant drop in efficacy. So after this, after you have seen this data, I'm eager to see whether you changed your mind slightly and whether you may consider now to do a resistance baseline test, at least in some patients with a more difficult to treat baseline situation. So what about your attitude now? What do you vote now? Yes in all patients, yes only in those with cirrhosis, and those with cirrhosis and treatment experienced status, or never, still never. So I see a little bit more yellow now, so I hope I have convinced you that for some subgroup of patients, really, baseline resistance testing might be very useful. So in summary, I think we clearly have made great improvements with the DAA combination therapies, even in those patients with liver cirrhosis. SVR rates are very good and very high, and in the majority of patients above 90%. We have an impact of the severity of liver cirrhosis. It impacts on the efficacy of the treatment, but also on the side effect and other adverse events. There remains uncertainty on the role of ribavirin. I think we clearly need more studies here. And we have seen that baseline resistance is associated with a decline of SVR in all the regimens we do have in our hands, especially if other stress factors are coming in addition along with baseline resistance. Christopher Zout will now speak about retreatment and future treatment options, and I will not go too much into this, but you will see that perhaps also for these subgroups of patients who failed to our initial DAA regimens, that also for these patients, resistance testing might be an interesting option. Thank you very much.
Good afternoon. Thank you very much for the invitation. And so the key objective of this presentation is to understand the implications of the development of resistance in patients who receive DAA-based treatment, and also to examine treatment options for patients who have previously failed DAA-based therapy, either peginterferon, ribavirin, and DAA, or patients who received interferon-free regimens. And I would like to start with the real-life patient case, a man, age 54 years, with genotype 1A cirrhosis. The cirrhosis was compensated and not advanced. And the Child-Pugh score was A5, and the male score was 8. So in May 2014, we decided to treat this patient according to the early access program with an interferon-free and ribavirin-free regimen, meaning daclatasvir in combination with sofosbuvir for 12 weeks. As you can see, the treatment was highly effective, and the HBV RNA was undetectable at week 8, and at the end of treatment, unfortunately, 4 weeks after the discontinuation of the treatment, HBV RNA was detectable, and this patient experienced a relapse. So I have a question for you, and this is how would you treat this patient? So cirrhotic patient, genotype 1A, and he failed to eradicate HCV with sofosbuvir and daclatasvir for 12 weeks. So the first option, the blue one, is retreat with the same regimen with an extension of the treatment duration from 12 weeks to 24 weeks. The second option, the green one, is change to a regimen with a different mechanism of action. And finally, The last option, the yellow one, is more information is needed before deciding how to proceed, meaning that you need to perform resistance testing before your decision. So please vote. So we have a majority of yellow after the talk of Christophe. It's good. So I don't know exactly what is the correct answer, but I work in Hôpital Henri Mondor with Jean-Michel Pawlowski. So HIV resistance was assessed using population sequencing, which target NF3, NS5A, and the polymerase. And we found NS5A RAV in these patients at the position 28. I think that this is a low level resistance as a position 28. So the first question is, what is the proportion of patients with a selection of RAV in those who fail to achieve an SVR with DA-based regimen? And we can start with this slide in patients who received Ledipasvir. These patients were included in clinical trials. They were infected with genotype 1, and they received Ledipasvir without sofosbuvir. And at baseline, as expected, around 15% of the patients had NS5A RAVs. But the situation was completely different in patients with failure, and at the time of the failure, 99% of the patients had NS5A RAV, suggesting that failure is associated with the emergence of RAVs. So it was for Ledipasvir. Now we can move to another combination with the 3DA from AbbVie. This combination associate a protease inhibitor, NS5A inhibitor, and a non-nuc polymerase inhibitor. So in this study, the patients were infected with genotype 1A. They received this combination. This combination was highly effective. The number of patients without SVR was low. 7 patients had failure. And the first message that, again, most of the patients without SVR had NS5A, NF3, or NS5A RAV. So there is an emergence of RAVs. This is the first point. The second point is that RAVs were observed in the 3 domains in some patients, NF3, NS5A, and also NS5B. And finally, failure was associated with additional RAVs. If you can see in the patient number 1 that at baseline we have 1 mutation in the NS5A domain at the position 93. And at the time of failure, we have 2 mutations. The mutations at the position 93 plus another new mutation at the position 28. Excuse me. So in summary, in most, if not all, patients who failed to achieve an SVR using an interferon-free regimen, viruses that are resistant to 1 or more of the DAs administered are present at the dominant species at the time of relapse. The second point is, what is the post-treatment RAV persistence in patients who failed to achieve an SVR with DA-based regimen? And I would like to start with this slide illustrating the replacement of PI-resistant viruses by wild-type viruses after failure to cimeprevir in combination with PEG and ribavirin. The patients were infected with genotype 1. They were included in phase 2 and phase 3 clinical trials and received PEG interferon, ribavirin, and cimeprevir, and some of these patients had no SVR. The first message is that more than 90% of these patients had NF3 RAVs as expected. The figure shows the persistence of RAVs, NF3 RAVs, over time. And the frequency was similar between the genotype 1A and genotype 1B, but as you can see, the mean time until NF3 RAVs became undetectable was shorter in genotype 1B than in genotype 1A, 24 weeks versus 36 weeks. But in fact, the difference was related to the type of the RAV. But the key message of this study and of this slide is that we have observed a significant and dramatic decline of NF3 RAVs over time. And this is a very important point because NF3 RAVs disappear over time. And it's interesting to note that in patients who failed with a triple therapy, including peginterferon, ribavirin, and telaprevir or boceprevir, when you retreat these patients with another first-generation PI, cimeprevir, in combination with peg and ribavirin, the SVR rate was 82% in the target cohort. So it's high, and it could be partly explained by the fact that this NF3 RAV disappear over time. But it's not the best way to treat these patients, and probably we need to use NS5A inhibitor for PI failure. Now, what is the situation in patients with NS5A RAVs? And we come back to the study including patients who receive ledipasvir without sofosbuvir. And as previously mentioned, at the time of failure, the vast majority of the patients, 99%, had NS5A RAVs. And these patients were included in the 3-year follow-up study. And it's very interesting to know that at the visit week 86, so 2 years after the failure, the vast majority of the patients had again NS5A RAVs, suggesting the persistence of the NS5A RAVs over time. So it's completely different from the NF3 RAVs. Now we can move again with the 3DA from AbbVie, and it's very interesting because we have a protease inhibitor, NS5A inhibitor, and an NS5B inhibitors. And as previously described, for the NF3 RAVs, we have observed a dramatic decrease of the proportion of patients with NF3 RAV. So again, we have a disappearance of the NF3 RAV over time. By contrast, regarding the NS5A RAVs, we have a persistence of the NS5A RAVs over time, as well as the NS5B RAVs. So in summary, after interferon-free treatment failure, HCV variants resistant to PIs progressively disappear in favor of the wild-type virus as assessed by population sequencing, and this may explain why HSV rate in PI-experienced patients in the HCV target cohort were still reasonably high, 82%. But in contrast, viruses resistant to NS5A inhibitors and polymerase inhibitor persist for years, maybe forever, as the dominant species, suggesting that the fitness of these NS5A RAVs is high. Now, another important point is the retreatment of patients with persistent RAVs after failure. So this is a very important study presented during the last EASL. The patients were treated for 8 or 12 weeks with sofosbuvir and ledipasvir. They experienced relapse, and they were retreated with the same regimen, sofosbuvir and ledipasvir, but the treatment duration was extended from 8 to 12 weeks to 24 weeks. And this strategy was a ribavirin-free strategy. And the key message is that the SVR rate was related to the presence of baseline NS5A RAVs. As you can see, in patients without NS5A RAV, the SVR rate was 100%. However, in patients with baseline NS5A RAVs, the SVR rate was 60% only, despite the extension of the treatment duration, suggesting that sofosbuvir and ledipasvir in this patient is not an appropriate way to retreat these patients. In fact, the failure was related to the number of RAVs at baseline, 69% for one RAVs, and 50% for at least 2 NS5A RAVs at baseline. And another important factor was the level of resistance. And as you can see, in patients with NS5A RAVs at position 93, conferring a high level of resistance, the SVR rate was low, 33% only. The number of patients is limited, but the SVR rate was low. Now we'd like to share with you our experience in our hospital of the retreatment of patients who have previously failed to daclatasvir-based regimens. We have 16 patients who are included in clinical trials, and they receive PEG-RIBA or daclatasvir, or PEG-RIBA, asunaprevir, and daclatasvir. We have 16 patients who failed to eradicate HCV with these two regimens. These patients had severe fibrosis, F3, or cirrhosis, majority of cirrhotic patients. As you can see at baseline, 81% had NS5A RAVs, and around half of the patients had always NF3 RAV. But you have to keep in mind that we have 3 patients who were previously exposed to asunaprevir, so exposed to a PI. And we decide to retreat these 16 patients with sofosbuvir and cimeprevir for 12 weeks without ribavirin. And as you can see, the SVR rate was high in this difficult-to-treat population. In the first 15 patients with efficacy data, the SVR rate was 87%. We have 2 patients who failed to eradicate with sofosbuvir and cimeprevir for 12 weeks. But now I can update for the overall population, the 16 patients, and the SVR rate was 88%. And we have, again, 2 patients with relapse. All genotype 1b and genotype 4 patients achieve SVR, and we have 2 cases of failure in genotype 1a patients. And I would like to focus on these 2 cases. The first case was a woman with a compensated cirrhosis, but with an advanced cirrhosis. And as previously mentioned by Christophe, we know that the severity of cirrhosis can play a role on efficacy, and now we know that the treatment of sofosbuvir and cimeprevir, or it's the same for sofosbuvir and daclatasvir, or sofosbuvir or ledipasvir, for 12 weeks without ribavirin is not an appropriate way to treat these patients with advanced cirrhosis. And probably that the best way to treat this patient is to extend the treatment duration or add ribavirin or both. So these patients have been probably under-treated. And it's interesting to know that at baseline, we have one NS3 RAV and one NS5A RAV. And at the time of failure, we found exactly the same RAV. So we cannot exclude that the extension of the treatment duration in these patients or the addition of ribavirin could prevent the relapse and the failure. For the second patient, this patient had a cirrhosis, compensated cirrhosis, but he was exposed to asunaprevir. He had received a quad therapy, PEG interferon ribavirin, asunaprevir, and daclatazivir. And it's interesting to know that at baseline, we have found the Q80K mutation and another mutation at the position 170. I don't know exactly what is the impact of this last mutation on cimeprevir, but we know, and Christophe has shown, that in cirrhotic patients, the presence of the Q80K mutation from the Optimis-2 study, the presence of this mutation has a negative impact on SVR. And at the time of failure, we identify this Q80K mutation. At baseline, we had also an NS5A RAV, but at the time of failure, we didn't find this NS5A RAV. So we cannot exclude that the presence of the Q80K mutation could play a negative role on the efficacy of this strategy in this patient. So here are the recommendations from the EASL recommendations. And so these recommendations are based on indirect evidence and may be subject to change as more data become available. The retreatment regimen should contain sofosbuvir due to the high barrier to resistance, and one or two other DAs, if possible with no cross-resistance with the DAs already administered. And third, it's recommended to add ribavirin in these patients. And finally, the treatment duration should be 12 or 24 weeks, but in patients with severe fibrosis or cirrhosis, the recommendation is to extend the treatment duration to 24 weeks. Now, the final point, what is the utility of HIV resistance? We have seen that in the previous talk that it could be useful in some situation in selected patients, but we have to keep in mind that we have a lack of standardization of the assay. We don't know exactly what is the best timing for testing prior to the therapy, at the time of relapse, at the time of retreatment, and we need guidelines for intervention and retreatment decision. I think that we need to generate data in order to select the patients who need to have this resistant testing before the retreatment. So now we can come back to our case. Just keep in mind that this cirrhotic patient has been treated with sofosbuvir and daclatazivir for 12 weeks. He experienced relapse. He had the NS5 RAVs at baseline. And so at the beginning of this year, we decided to retreat these patients with cimeprevir, sofosbuvir, and ribavirin for 24 weeks. It was before the EASL guidelines, but we have followed the EASL guidelines. And the very good news is that in July, so 1 month after the discontinuation of the treatment, this patient achieved SVR4. And so we hope that in 2 months, these patients will achieve SVR12. So in conclusion, the vast majority of post-treatment relapse is due to resistance. PI resistance appears to reduce over time post-treatment, whereas NS5A resistance appears to persist long-term. Patients who have failed the regimen should be rotated with a different DA class, and these patients to be also receive ribavirin if they have severe fibrosis or cirrhosis, and should extend treatment duration to 24 weeks according to the EASL guidelines. And to allow the best selection of treatment, resistance testing may become more important in the future, but we have to define the good candidate for resistant testing. Thank you very much for your attention.
Thank you, Christophe, for that very interesting data and also new data on retreatment of patients who failed to DAA combination regimens. We now have 15 to 20 minutes to discuss the three presentations, so you're invited to ask your questions. Don't be shy, just raise your hand and ask your questions if you have some. I think we can start with the first presentation, Ashley, on the easy-to-treat patients. I would be very interested to know about the situation in the different countries in Europe. How frequently is an 8 weeks treatment really used in the real-world setting? So tell me about England. Is that something you're really doing? Can you do that? Do you have to do that based on the baseline predictors, or is it something which is not allowed?
Thank you. The situation at the moment in the UK is that we're only treating cirrhotic patients, and I think that nobody is sufficiently yet brave enough to be reducing treatment to 8 weeks in cirrhotic patients. I think the question will arise when we expand into treating non-cirrhotics. As you'll appreciate, the whole of the UK program is based around cost effectiveness. And I think there is certainly a very good cost effectiveness argument for shorter duration treatment in non-cirrhotic patients. So I think it will all come down to economics in the UK. Okay. I think the other thing that's quite interesting, of course, is that those patients with shorter duration treatment seem to be less likely to breed out those resistance mutations that we were talking about at the end, and that there may be a double benefit from shorter duration treatments. Who knows?
So that remind me, your patient treated for 12 which should have been treated for 12 weeks. He was a non-cirrhotic.
He was non-cirrhotic.
So why did he receive treatment then? If only treatment is available for cirrhotics in the UK.
Extrahepatic manifestations is one of the exclusions.
So you can come around this.
Yeah, we're already talking about how we're going to expand that program. The plan in the UK is that we will have treated we've already treated all of the decompensated cirrhotics in England. We're planning to treat all of the compensated cirrhotics within the next 12 months, and then we will talk about how we expand the program.
So in France, Christophe, what about 8 weeks treatment in France? Is that something you are doing? Is that something which is of no importance?
Yes, so based on our recent recommendation guidelines, the 8-week regimen is not recommended, but the reason was that the analysis showing that it's possible to treat patients with a low viral load was not published and was not presented in an international meeting. Okay. This was the main reason. The second point is that in France, all indication of treatment must be validated in reference center. And so in practice, it's not recommended, but in some reference centers, patients with low fibrosis stage, meaning F0, F2 with less than 9.5 kilopascal, naive patients, and with low viral load, less than 6 million or 6.7 log. In some reference center, the 8-week regimen is validated, and so some patients are treated with this short treatment duration.
I think it was quite interesting. We heard earlier on from NID that in the US, where the payers are prepared to pay for anything, that despite the evidence that the majority of physicians are still using 12 weeks. I think the drive will actually come from the payers. Yeah. I think that once the evidence is out there, the reimbursement companies, the insurance companies, in my case the government, will say, well, we're not going to pay for 12 weeks because it's not necessary.
But perhaps Ira can comment on this, because I have heard that you're even obliged to treat for 8 weeks, even if you don't want to do so. The payers will give out the third package of tablets, and the patient can get only 8 weeks. Is that true, Ira? Okay.
Naive, non-cirrhotic. Yeah. Viral load is less than 6 million. We get 8 weeks of coverage most of the time.
Interestingly, some of the carriers have been willing, when we submit the data, that if the HCV RNA is still detectable at week 4, they'll extend the therapy, which is not evidence-based.
It's not logical,
but
is
we're
it?
happy
Yeah.
to take it.
Yeah.
And in those that fail treatment on the shorter duration, do the insurance companies or the payers then fund a second course of longer duration, or is it one go and that's it?
My only 2 failures so far have been 12-week treated patients, so I don't know.
And how happy are you with the cutoff of 6 million? I mean, if I reviewed the FDA analysis on that, I saw all the different cutoffs from 1 million up to 10 million. I recognized that for none of these cutoffs there was a significant difference. So they just took the best p-value, which was around p 0.127 or so. Is that really worthwhile to follow?
It's interesting you say that, because I haven't seen those data with the individual viral range cuts. I've urged my friends at Gilead to get this published in an academic publication one day, but it hasn't happened yet. So I'd like to see that analysis, but what they've told me verbally is that the real cutoff is 10 million, and that they made it 6 to have a margin of error in an effort to make clinicians more comfortable accepting that 6 million cutoff.
So I'm really struggling, but because in addition to the uncertainty of the correct cutoff, we have also differences for the different assays we are using. So in the approval studies, different assays, or a different assay has been used than in the real world setting, and there are significant difference in quantification. We just presented data at the EASL that with the real world assays, 80 to 90% of the patients will be below 6 million international units. So almost in all patients you have to shorten down the treatment, and we don't know what this means for the relapse rates. So I think 8 weeks is nice, but we are not really there to be sure that patients will not relapse. But you mentioned that you don't fear the relapse because there are not so many with NS-favorable resistance, and then you can retreat them easily?
I don't think you can. I mean, the evidence is there that I think it's continuing treatment when they're clearly not working that's probably likely to breed out these resistance mutations. And we're all talking about now the fact that we're not monitoring on treatment. There is no indication for doing viral loads during treatment because there is no response-guided therapy. There's no futility rules. And I just wonder whether we're losing something, that whether patients who are still detectable after 4 or 8 weeks, those should be the very ones that we should be thinking about stopping and trying with something more effective.
So last question on the 8 weeks treatment. How confident would you be to take IL-28B CCs into account, to take the females into account? These were all significant predictors. Is that something you would
I'm not convinced that they were significant predictors. I think they showed trends. I'm afraid I've always been a bit of a cynic about the role of IL-28B. I think that when we start, we're looking forward to an era where we're going to be treating large numbers of people, and I think making it more and more complicated at baseline is probably going to be counterproductive. I'm a firm believer of let's treat everybody and then worry about the 5% of treatment failures at a later stage, rather than putting a lot of resources at the front end and trying to individualize medicine for every patient at the start. But that's just my personal view.
Yeah, I fully agree, and it's really too complicated. So we take into account only viral load.
So make it easier. So that's the trend.
Yeah.
So let's come to the cirrhotic patients. What is the standard here? Using ribavirin, 12 weeks, going for 24 weeks without ribavirin. What about the stage of cirrhosis versus your personal cutoff where you don't treat anymore because you may harm the chance of liver transplantation? So what is the strategy in England? Let's start with you, Ashley, first.
Okay, so the strategy with ribavirin is that our gut feeling, I think, is, as Graham Foster said in his earlier talk, that it's cheap as chips. It probably nudges up the SVR rate by a few percent. And so in principle, we start everybody on, all our cirrhotic patients on ribavirin, unless there's a very good reason not to. We have a low threshold for dose reducing or even discontinuing, but my feeling is that if you put a patient with cirrhosis through treatment without ribavirin and then they fail, you're going to kick yourself because you hadn't done everything that was possibly there. Mm-hmm. Now, I think that the evidence will start to come out, and I hope that the English cohort, where we're expecting to treat 5,000 compensated cirrhotics and collecting data, may be able to tease that out a little bit more. Ironically, even our genotype 1b cirrhotics on AbbVie, we're still putting on ribavirin despite the turquoise 3 data. So I think for the time being, we would err on the side of caution, and if the patient can tolerate ribavirin in cirrhosis, then we would give it to them.
I don't want to be again the devil's advocate, but what about ribavirin plus sofosbuvir? 2 nukes in cirrhotic patients, if you have an advanced cirrhosis, this may cause trouble. We have some experience, few patients with lactate acidosis, with increased numbers of infections. I don't know whether others have similar experiences. What about you? I mean, 2 nukes in a severely cirrhotic patient could be harmful, could be dangerous.
I guess so, and we've certainly had patients that on treatment with advanced cirrhosis that have run into problems. I think it's very difficult to tease apart how many of those patients would have been sick anyway, and what contribution those drugs make to it. I mean, Chris, would you use it?
Yeah, but we have some poor experience in child C patients, and currently we treat less and less patients with sofosbuvir-based therapy and ribavirin in child C patients. We try to define the cutoff with the MEL score, and perhaps it's around 18 or 20, something like that. But we have some poor
The point is, though, is whether that child's PUC patient has the option of transplantation. And I think if they are a transplant candidate, then I would completely and utterly support the argument that we should transplant now and treat later. The reality is that an awful lot of my child's PUC patients are never going to be accepted onto the transplant program. They're either still drinking, they've got social issues, they've got other comorbidities. And I think for those patients, this is their last chance, and I think we can get people through infections. We ended up on our decompensated program actually having to admit quite a few of these patients. They spent time as an inpatient on treatment, but nevertheless, we're now seeing a year or 2 out that they're beginning to improve. So the ones that didn't die are doing well.
So you really see that. That's another devil's advocate question. We always see these waterfall diagrams, the child puke score tables, and we get the impression these patients are getting really better. But keep in mind, these are data at the end of treatment, at follow-up 4. We have no data for 12 weeks or 24 weeks or even 1 year. But what we really want to know, of course, is the long-term outcome of these patients. Are these child B or C patients really substantially and sustainably improving over time? What is your personal experience, Christophe, in France? You have treated a lot of severe cirrhotic patients. Do they really improve in the long-term one, or is it just eradication of the virus, but then at the end?
Yes, I think that if they improve, they improve during the first 3 months. Yeah, and after I think that the situation remains stable, but we have some significant improvement of hepatic function. But it's really during the first 3 months and after is stable.
The other determinant, of course, is what other liver diseases are going on. We know that the patients that have got coexistent NASH or alcohol or whatever else are very much less likely to improve simply by eradicating their hepatitis C. And and in that cohort of sick people that we treated, many of them had other liver cofactors that are simply not going to go away with the course of antivirals.
So let's move on to resistance. We have really learned here with the 3 presentations that resistance is of importance, especially if other stress factors are coming in addition to baseline resistance. So the first question to the audience would be, as we have heard, that baseline resistance testing is nothing you're doing in your clinical routine frequently. So the first question is it available at all for you? So can you do that? Perhaps simply a vote with green and red. So if you have resistance testing available in your own setting, in a lab, in your own clinic, please vote with green. If not, please vote with red, just as an impression here from the audience. So it's more or less half-half, if not more are voting with red, right? So it's not available in the majority here of the local settings. Is it worthwhile to speak about resistance testing then at all? Ashley?
Like anything in medicine, you only do an investigation if it's going to alter your management. It's as simple as that. Remember that in a lot of these countries, patients are paying for all these additional investigations. For us, it's not a problem because it all gets lumped into the big pot. But for some people, they're paying for resistance testing. And if we really had a beautiful armamentarium of different drugs that we could select a new NS5A that hasn't got cross-resistance, and it really is NS5A resistance we're talking about here, then fantastic. The reality is at the moment, we only have access really to 2 NS5, well, 3 if you include the AbbVie, but 3 drugs which have got huge cross-resistance issues.
Yep.
So rattling off all those numbers is fantastic, apart from the fact that it's not actually going to alter your management. So why waste money? I think it would be very different when we've got 2 or 3 new second-generation NS5As on the market, when we really will be individualizing treatment failure patients. But at the moment, I think we're just throwing good money after bad, to be honest.
Christoph, you're in a convenient situation. You have Jean-Michel Pawlowski. He's doing all sequence analysis you want to have. Are you doing it in all of your patients? Are you doing it in cirrhotics? What is the...
No, so we perform resistance testing only in patients who fail to sofosbuvir-based regimen or to the AbbVie regimen, only in these patients.
Okay.
And after we try to adapt the retreatment according to the results of this resistance testing, meaning that, for example, in sofosbuvir plus daclatazivir or sofosbuvir lidipasvir treatment failure patients, if we find only NS5A mutations, we treat with sofosbuvir, cimeprevir, 24 weeks plus ribavirin only. If we find the Q80K mutation, we combine sofosbuvir, daclatazivir, cimeprevir, and ribavirin for 24 weeks. If we have NS5A
Who's paying for that?
I was going to say, my NHS commissioners, I can just see them going pale at the thought of that. But,
yeah, this is our habits. And if we have NF3 RAB, but not the Q80K mutation, it depends, and really we don't know exactly what to do.
Okay. So final question to you, Christoph. You have shown us your 2 relapse patients, and for these 2 patients it looked very clear because they had baseline resistance. One had even the R155K by chance. The other one was exposed to azanaprevir and had the Q80K plus another one. So I think for these 2 patients, it's an evidence that baseline resistance was of importance. However, you had a larger number of patients who achieved an SVR. So did you also baseline resistance analysis in these patients, and what did you find in these patients?
Yes, so we find NS5A arrives in more than 80% of the patients, and also in around 50% of the patient NF3, and we have no relationship between the baseline drives and the outcome of the treatment. And we have another patient with a Q80K mutation. He was treated with sofosbuvir and cimeprevir with ribavirin, and he achieved SVR. So I think it's very difficult to predict.
It seems to be more complicated.
Absolutely.
They are open questions we have to answer, and we are in time. It's now sharp 7 o'clock, so it was a long day. We will let you go now, but not without completing here the evaluation form. Please mark or tick on the right side or on the left side if you want. I would recommend the right side. Thank you very much for attending this late symposium. I wish you a nice evening and then also a successful congress tomorrow and on Saturday. Thank you very much.
Thank you.